Can we start, Shivam?
Yes, ma'am.
So, good evening. Welcome to each and every one of you who have logged in for this evening's quiz on Kahoot. This is from the quiz committee. Regards to everyone. And today's topic is ovulation induction. So we have 20 interesting questions, which will, as usual, come through the Kahoot model. And you would go on a timeline with so many seconds, around 20 seconds to answer each question. And I hope all of you find it as a useful exercise to brush up on your ovulation induction facts. So I request Mr. Shivam to go into the quiz module. And good evening to the participants. I'm sure you have played this many a time. So there comes your game pin, 3499147. Requesting whoever has logged in to join in. These are pretty basic questions, and ovulation induction is something we do each and every day.
अभी 5 मिनट हो गया देखिए स्टार्ट हो रहा है आ रहे हैं
Shivam, we'll give them a minute more. Then maybe the others just want to watch it.
Yes, ma'am.
Yes. Shivam, shall we start?
Yes, ma'am, we can.
Yeah, then let's go ahead. The WHO classification 3 stands for hypogonadotrophic hypogonadism, hypergonadotrophic hypogonadism, normogonadotrophic hypogonadism, hyperprolactinemia. The answer is hypergonadotrophic. Ovaries are supported by the following ligaments except suspensory ligaments: broad ligament, tubo-ovarian ligament, round ligament. Round ligament is the answer. Estrogen has three main functions except negative feedback on FSH, positive feedback on FSH, positive feedback on LH, proliferation of the endometrium. Positive feedback on LH is the answer. So estrogen levels must reach the level of dash picograms and remain for at least 48 hours for LH surge to happen. The values are 300, 150, 200 and 350 picograms. The answer is 200 picograms. During the intrauterine life of a female, there are 7 million oogonia that reduce to only so many million at birth, which is 4 million, 1 million, 5 million, and 6 million at birth. One million is the answer. Corpus luteum releases all except progesterone, inhibin A, estrogen, activin. Activin is the answer. Ovulation induction is contraindicated in all except hypogonadotrophic hypogonadism, bilateral tubal disease, liver diseases, unexplained infertility. The answer is unexplained infertility. Clomiphene citrate is a mixture of two isomers, N-clomiphene and zoo-clomiphene, in a particular percentage, which is 50-50, 50-48, 60-38, 40-58. Right, it's perfect score by most, it's 60-38%. The aromatase enzyme of granulosa cells convert what to estrogen? Testosterone, dihydrotestosterone, monohydrotestosterone, and androstenedione. Right, it's androstenedione is the answer. Clomiphene resistance. If patient fails to ovulate despite 6 cycles, despite 4 cycles, despite 5 cycles, and despite 3 cycles. Answer is fails to ovulate despite 6 cycles. Following are true about letrozole, except aromatase inhibitor, endometrium is not thin, half-life is 4 days, no risk for multiple pregnancy. The half-life is 4 days is the answer. Now, clomiphene is all except not an FDA-approved SERM, a 6-month live birth rate of 20 to 40%, treats oligoovulatory infertility, used alone or with an adjuvant. The answer is not FDA-approved selective estrogen receptor modulator. Now, the clinical outcome of gonadotrophin ovulation induction, all is true except hypogonadotrophic hypogonadism, the pregnancy rate is about 25%. WHO group 2 anovulation, the pregnancy rate is around 5 to 15%. WHO group 2, the pregnancy rate is around 50%. And PCO patients, cumulative pregnancy rate is 30 to 60% after gonadotrophin treatment. The answer is the pregnancy rate of 50%. We have 6 more questions to go. Recombinant gonadotrophins offer several advantages over urinary preparations. Higher purity, batch-to-batch consistency, absence of non-gonadotrophin proteins, and 4 types of variants. Four types of variants is the answer. All right. Clomiphene has the following features except endometrial thinning, cervical mucus thickening, long half-life, and clomiphene resistance is less than 10%. The answer is clomiphene resistance less than 10%. The risk of OHSS with injection gonadotrophin is all except 20 to 30% mild OHSS, 0.1 to 2% severe OHSS, 3 to 6% moderate OHSS, 4% of severe OHSS. Right, 4% severe OHSS is the answer. Ovarian size is more than so many centimeters in severe OHSS. Is it 7 to 8 centimeters, 6 to 7 centimeters, 8 to 10 centimeters, or more than 12 centimeters? More than 12 centimeters is the answer. The following are more prone for OHSS except the young, the genetically prone, letrozole, and polycystic ovaries, PCO. Right. So, following are not prone for OHSS except. Did I get that wrong? The following is true about aromatase except converts androstenedione to estrone present in ovaries, adipose tissue, placenta, brain. Cytochrome P450 containing enzyme. First generation aromatase inhibitor is letrozole. Yeah, all of you got it right. It's the fourth response, first generation. So the last question. Effective ovulation induction is possible using the following except clomiphene, letrozole, tamoxifen, insulin sensitizers. Yes, it's insulin sensitizers. So thank you so much for the participation. Let's see who have been picked as the winners. All right. So that's Priya out there. And then comes, I would request whoever has been chosen as the first, second, and third. Right? You've done a great job of speed and the right answer. So thank you so much for the participation. And Fertivision is waiting to see you. And Ahmedabad is right there. Okay, so 6, 7, 8 of December is when the event is happening. So we'll be pretty happy to have you there. And Priya, looks like you've enjoyed your participation in your quiz and you took a place there as well. So thanks for others who also watched in. Shivam? Shivam?
Yes, ma'am.
Yeah, you just have to note down the winners, right? And get
Yeah,
hold of
I
their
will share.
names. Yeah, and get hold of their names so we can send them. Pardon? So that we can get the
Yes, ma'am, I will
certificates
share.
ready.
I will
Yeah,
share on
yeah.
WhatsApp.
So that we'll have the certificates ready for them, right? So I just request you to note them down. Sushmita?
Hello, yes, ma'am.
Yeah, if you're good to go, we can move to the journal club session.
Yeah, shall I share my slides, ma'am?
Yeah, just give me a moment. Can I request you to introduce yourself when you are out there? I think Dr. Sujata is also logging in. Priya? Priya?
Yes, yes.
Yeah. Dr. Sujata has now sent me a message. Shall I log in? Sure.
Yeah, Sujata has logged in.
Okay, fine.
Yes, she is logged in.
Okay. Fine, if she's logged in, then it's great.
Then you go ahead with her.
Yeah. I'll go ahead with her. So thank you so much, but thanks for taking a place in the quiz score as well. So my special thanks to Dr. Priya Kannan, Secretary of IFS Tamil Nadu chapter. I brought in her as a rescue expert, right? And I would now invite Dr. Sujata to join us for the journal club session this evening. Dr. Sujata Ramakrishnan is the head embryology of the NOVA group of fertility centers. She is an American Board of Bioanalysis certified embryology lab director. And she's also done a lot of research work. She was previously with Kraft and Cloud9 and has more than 25 years of experience. And she's currently the president of the Academy of Clinical Embryologists. And I would then be happy to invite Dr. Sushmita. Dr. Sushmita is
Yes, ma'am.
currently,
I will
yeah,
share
yeah.
my slides.
Just give me a moment.
Okay.
Just give me a moment. So this evening, the topic is intracytoplasmic sperm injection. Is it still the best management for the male factor of infertility? And as you're getting ready, you can start screen sharing, Sushmita.
Okay, ma'am. Is my screen visible, ma'am?
Yeah, it is.
Is it now full screen?
Yeah, it is. So
Okay.
I invite Sushmita to give her presentation this evening on this topic. She's a final year MCH resident at Sri Ramachandra Medical College, Chennai, Porur. Dr. Sujata?
I'm there.
Yeah.
Good
yeah.
evening, all. Thank you
Yeah,
very
yeah,
much for
yeah,
having me
yeah.
here. I'm there.
Yeah. Right. So shall we request her to start the presentation of this paper?
Yeah, please do, please.
Yes, Sushmita.
Thank you, ma'am. Good evening, all seniors and colleagues and friends. Today I will be presenting to you this article, which I found very interesting. This was intracytoplasmic sperm injection. Is it still the best management for male factor infertility? This is published in Fertility and Sterility in April 2024, which has an impact factor of 7.49 and a site score of 11.3. It comes in quartile 1. It is actually a debate between IVF and ICSI. It's a fertility battle, and these authors have given their opinions on pro ICSI, while Mr. Robert John Atkin has spoken on what are the cons of ICSI. Coming to how is IVF performed, we all know that once the oocytes are retrieved, they come as in the form of cumulus oocyte complexes, and once the sperm is prepared, they are injected into the petri dish and kept for culture overnight. Fertilization is noted after 17 to 18 hours. For ICSI, in severe male factor infertility, such as severe oligozoospermia or asthenozoospermia and teratozoospermic patients, go for ICSI. In these cases, we retrieve the oocytes, but we go one more extra step, which is denudation, to note the nuclear maturation of the oocytes, following which there is one ICSI manipulator which has to be adjusted, and the sperms are directly injected into the M2 oocytes. So there are various natural selection barriers which are there in IVF, which are crossed in ICSI, such as the zona pellucida, acrosomal reaction, and fusion of membranes, etc. Um, as because the gametes are manipulated for a longer duration of time outside of the incubator in ICSI. So the laboratory environment becomes very crucial for the ICSI success. In cases of high temperature, patients have noted parthenogenesis in oocytes. And in cases of low temperature, there are mitotic spindle polymerization, which thereby leads to non-disjunction and aneuploidy. IVF, on the other hand, is devoid of these things because we directly inseminate and put them into the incubator. ICSI is also very time sensitive. The timing of trigger to oocyte retrieval and then denudation is very important for the nucleocytoplasmic maturation. And once the oocytes are denuded, they cannot be kept out for long and has to be injected immediately. Again, there is a role of acrosome in the acrosomal reaction, which is bypassed in ICSI. But in patients such as globozoospermia who are devoid of acrosome, and in them, ICSI is the only method of fertilization, which gives a pro bono point to ICSI. Again, centrosome of sperm takes an active participation in separating the chromosomes during meiosis in the zygote. There are cases of three pro-nuclear embryos, both in IVF as well as ICSI. Whereas in IVF, it is because of the sperm polyploidy. In ICSI, it may be because of non-disjunction of the second polar body. So ICSI has given us this knowledge that what is the role of sperm centrosome in meiosis. Again, novel gene mutations in the sperm may lead to failure in both IVF as well as ICSI. So studies of sperm genome has proved that certain genes which trigger the calcium oscillations for oocyte activation, embryonic implantation, and mitotic microtubule stabilization and trophoblast development, if they are defective, may lead to failure of ICSI as well. So cases of poor fertilization, poor embryo development, and failed implantation and pregnancy loss may go ahead with sperm gene studies. For sperm gene studies, we can select a single sperm and then plunge it into the oocyte. Again, cases of complete fertilization failure are more common in IVF compared to ICSI, and subsequent ICSI with a calcium ionophore treatment will lead to a successful fertilization in these patients. There have been cases of poor embryo development in IVF, where patients have noted that increased DNA fragmentation index in the sperms may be one of the cause, and special sperm sorting devices such as microfluidic sperm sorting have been known to give us better quality sperms with less DNA fragmentation. Again, genetic and epigenetic profiling of infertile patients have shown that advanced paternal age is more prone for high DFI as well as sperm aneuploidy, which has given a better uh, insight into the genomic and epigenomic studies. These have given us an explanation of why some cases of unexplained infertility fail fertilization. This would not have been possible if we would have not have selected the sperm for ICSI. There are certain add-ons to ICSI such as MSOM, MC, PIXI, sperm DFI, sperm histone studies, sperm ploidy, sperm genomics, and sperm sex selection, which are newer upcoming add-ons, which have helped to improve the fertilization rate with ICSI. Coming to MSOM, MC, the morphology, a better morphological sperm is always known to have a better DNA, and therefore studies have been done. Some studies told that MSOM MC gives us a better fertilization rate, but with fish on sperms and tunnel studies, they have found there is no correlation between the presence of nuclear defects observed through high magnification microscopy and chromosomal imbalances or DNA fragmentation of sperm. Now, physiological ICSI, or also known as PIXI, has taken into the account that hyaluronic acid present in the cumulus oophorus selects the better sperm, and hence petri dish coated with hyaluronic acid have been used to select sperms. Most studies did not see much relevant benefit, but with fertilization rate, but they had shown slight reduced pregnancy loss rate. So there are various ways to select the ideal sperm by checking their DNA fragmentation index, out of which SCSA, sperm chromatin assay, is a gold standard ones, followed by tunnel assay and sperm chromatin dispersion assay. Also, in patients who have high DFI, testicular sperms have been noted to give us a lower DFI and a better quality sperm. And testicular sperms can only be used in ICSI and not in IVF. Microfluidics also gives us a lower DFI sperm. Again, sperm histone content is usually the sperm DNA is compressed with the help of histone modification, and the linker DNA are the places where they are more prone for damage. Sperm histone studies are recently coming up to get us select a better sperm with less DNA damage. Now coming to sperm ploidy, sperm being a haploid structure, any aneuploidy in the sperm DNA itself can be crossover to the next offspring. So studies with fish and next generation sequencing has helped us get male germline, get across male germline aneuploidy, and complex cases such as chromosomal translocation can be dealt with such investigations, and this can be only possible when they are accompanied with ICSI. Nowadays, many sex chromosome related diseases can be prevented with the help of sperm sex selection. It has been known that the Y chromosome is a lighter sperm. Hence, when a density gradient centrifugation is done, Y chromosome may be retrieved in the upper 20% part, and the X chromosome may be lying in the lower 90% part. Although this has reached to only 80% rate of confirmation of the sex as of now. Again, sperm flagellar motion analysis has also come up, but these are still in research purposes. So now ICSI has become, previously it started like ICSI was the last method to use when the male factor was so severe that it was not possible to go for IVF. But now ICSI has become the go-to method of choice for all kind of fertilization. More than 90% cycles are currently doing ICSI. So that's why this article talks about the safety of ICSI. This has been shown in many studies that although we are questioning about the ICSI safety, but height, weight, and medical characteristics, congenital and major malformations have been non significant when compared between IVF and ICSI. Also, ICSI is now the most commonly used insemination procedure, but this has made ICSI more prone to be employed for non-male factor infertility, which is why is the concern. Nowadays, ICSI is most commonly performed for advanced age women in whom the cause of infertility may be raised oxidative stress and aneuploidy. Also, in unexplained infertility, again, where oxidative stress and genetic mutations may play a significant role, in whom injecting a sperm directly into the oocyte may not solve the problem. So studies have been done in which they have seen that there has been no improvement in ICSI in non-indicated cases. Again, with ICSI, the cost goes high up. The depth of investigation such as MSOM, PIXI, everything adds on to the cost to the patient. And there is also risk of damage to the oocytes because of the mechanical manipulation. Also, it depends upon the skill of the embryologist and the sharpness of the instruments that we use. All this may lead to more cost and loss of more oocytes. Hence, we might be doing more harm than good with ICSI for all. ICSI has also killed andrology because any kind of sperm, if it is alive anywhere in the genital tract, can give you a fertilization. With such sperms, we may be propagating all kind of mutations, and this may not have an immediate effect on on the children, but on the long term, we might see that children conceived with ICSI have either high adiposity, mostly in girls. Men born from ICSI have decreased spermatogenesis. There is increased miscarriage rate compared to IVF babies, and low birth weight. And some cases have come with increased neuropsychiatric diseases and autism. The important question to ask is, does the use of DNA damaged cells in ICSI procedure impacts the mutational and epi-mutational load carried by the offspring, and this later developmental normality? So, human genome has 3 billion base pairs, out of which only 1% code for proteins. So, it is very unlikely that one mutation among all these base pairs may lead to pathology. So, this, even if ICSI has an effect on the human genome, it may be negligible as of now, but on the long term, these mutations may accumulate, and we might have a long term effect on our species. So absence of evidence is not equal to evidence of absence. Um, this journal states that more and more use of ICSI for cases such as AZFC deletions, primary ciliary dyskinesia, and zona pellucida 4 mutation may propagate all these mutations in our progeny, which will affect the fecundity of the species. So it states that our long-term goal should be to invigorate the research into the etiology of the fertility, so that we can develop targeted therapies for defined pathology and reserve this remarkable ICSI technology as a refuge for last resort for severely infertile men. Thank you.
Yeah, thank you, Dr. Sushmita. It was a wonderful presentation.
Thank you, ma'am.
So we have expert with us, Dr. Sujata. Any comments, any input you want to give for this?
So, thank you very much, first of all, for having me here. And Sushmita, that was a very nice and a clean presentation. And the article also, I feel it's kind of the need of the hour, because, you know, like the percentage of ICSI cycles have gone up tremendously, not just in our country, but everywhere else. But in our country, I think there are programs which are moving to 100% ICSI. Okay, so there are few things here which, you know, like, I know a lot of you are not embryologists or medical infertility specialists, and it is very important that you all know that. See, the main reason why people opt for ICSI is for the fear of fertilization failure. Okay, but you know, studies they say that fertilization failure, if you just look at large number of cases, it is not very different. Even in ICSI these days, you get lot of fertilization failure, especially with all these, you know, like the short protocol. Like you get lot of degeneration and you do not get enough embryos after ICSI. So, like, I think it is the fear of counseling the patient that this cycle is useless. I think people opt for ICSI. And as Sushmita had rightly pointed out, ICSI had actually killed andrology, which is, like a few years back, like when we all started, there was so much importance given on sperm analysis, sperm separation, sperm selection. But because of ICSI, that is kind of slowly dying down. I think, more importance has to be given to andrology. And third thing is, people really have forgotten how to do IVF. Like I do not know, even the students these days who are finishing their masters in clinical embryology are even trained to do IVF, because like how many sperm per egg, and then what should be the sperm quality, can you do it for all kind of sperm, and what should be the insemination time? Should it be long insemination or, like short insemination? All these things I think are not taught. So people, they don't, there are so many embryologists coming who actually has not even witnessed a single IVF cycle. So definitely, I think a dialogue on this or a conversation on this is very important. And the last point which I would like to mention is, I was reading a paper the other day where they looked at, consistently well-performing clinics in the US. Okay, and then they were trying to find out what are the key things which all of them are following, like common things which are followed by these centers, which are always giving good results. There are many, out of which one is, it says like selective use of ICSI. It didn't say that, ICSI for all. So whomever are doing ICSI for the actual needed patients, their results would always be better. So I really feel that this is a good conversation, like which should be initiated, especially when the conventional IVF is dying down.
I invite Dr. Neeru Takral also to give some comments. She's a national coordinator for the Young Turks Club. And we have our ever enthusiastic Dr. Nisha Bhatnagar. And it's actually nice to have Dr. Sujata herself to say that IVF is actually getting lost. The last 10 years, I think this turn has happened, right? Towards
Yes.
ICSI.
Yes.
And with the situation that mild stimulation, less eggs, maybe it's a matter of numbers that we're having lesser eggs and lesser sperms, that we are playing safe by going towards ICSI.
Hi, Dr. Rajipta.
Studies actually have shown that even in less number of oocytes, like there is no big difference between conventional IVF and ICSI. I think it is just that myth which is created that if you do not do ICSI, you may not get good embryos. I think has pushed people to opt for ICSI in these cases. If you just go through that ASRM position paper, right? Like there they have actually segregated all of them. What happens in elderly patients, what happens in less number of eggs, all these places, it is actually the superiority of ICSI has not been demonstrated or been proven.
I think Dr. Sujata, you said very rightly that I think case selection is the most important thing. The whole debate, when when we are talking, when we are discussing, the things are on the academic level. But when for a patient coming to you, putting up somewhere around 1.5 to 2 lakh cost, I think this is the ever going discussion between the embryologist and the clinician. I do favor IVF. I have for single eggs also. This is Dr. Nisha Bhatnagar. For single eggs also, I do a lot of mild stimulation. We have done IVF. But at the end of the day, if it doesn't result in a good embryo, or if it doesn't, there is this question always in your mind that should we have done ICSI, should we have gone for ICSI, because mild male factor is very, very common these days. It's very rare that I see that there is more than 1% morphology. I don't know if they follow the strict WHO criteria. There is always reports showing 1% morphology. So for this cases, when the embryologist tells us the next day, okay, ma'am, it's not a good embryo, or it's not resulting in a good thing, So back of mind, this is always there. That was there some sperm parameter? Because I have got a good egg. She's young. She's no other factor is there. There is tubal factor. So why then? We have taken one single egg to day 5, blastocyst, resulted in a pregnancy. But whenever there is a problem, this thing is always in the back of the mind that if I had done ICSI, I would have selected one good sperm instead of putting, nature selection or something. I don't know. Can you please put some light on that?
See, this is the thing, like, see, some of you voice it out. Some of us don't, okay? We actually act very confident, but actually this thing goes on in our mind also. Did we suggest the right thing? Had we said the other option, would it have worked? So, this is common for all. But what I'm trying to say is, since I'm seeing a lot of cycles these days, what is happening is there is some, uh, lack of coordination between nuclear maturity and cytoplasmic maturity. Okay, this is
Okay.
something which we are observing a lot in the last 2-3 years or so. So when there is no cytoplasmic maturity, what happens is the moment you stick the needle in, the cytoplasm oozes out and it degenerates. Okay, so in
But
this
that
case,
we can pick out with our like sort, if we are keeping all the KPIs, then we will come to know about that by our degeneration rate or M2, like fertilization rate or something that will tell us, no, that if there is excessive, if there is a lack in cytoplasmic maturity, can we make out by some KPI?
no.
I think yes. No.
No,
Okay.
that cannot be. See, there is no marker for cytoplasmic maturity. Okay, to be very honest. At least here in nuclear maturity, you look at the polar body and then say that this egg is mature. But cytoplasmic maturity, you don't. It is actually the feel. And you can feel it only when you stick the needle in. And the moment you stick the needle in, the ooplasm oozes out. And unfortunately, I don't know whether it is the lack of knowledge or the lack of courage to express that many embryologists do not report degeneration at the time of ICSI. Okay, they just, the next day they might even say that it is unfertilized. And if you just look at the egg, you would realize that it is gone. It's a degenerated one. So, that degeneration, if you are actually following degeneration rates in your lab, then, like you will have an idea. See, now I have only 3 eggs, whether I should opt for ICSI or IVF. We are expecting a degeneration rate of anywhere less than 7%.
Okay. Okay.
So it is not only the embryologist skill, there are so many things,
Yeah.
right?
Yes.
Yeah.
So many things.
So, like, because of that, I'm saying, like, I have seen ICSI cycles also not resulting in any embryo, not even
Yes.
a zygote.
Agree.
So then, at that moment, you sit and think, maybe if I had done an IVF, all I would have had is unfertilized. I would have known it for sure. But at least this thing, oocyte, would not have been degenerated. So I think these days, especially with the kind of patients, like you get lot of oocyte abnormalities, and then I do not know, but these days nobody does this, that agonist protocol for very long days, where at least you can be sure of the oocyte quality. You get lot of these fragile oocytes. If you just, overall, if you look at the reports from the labs, there are a lot of people reporting, fragile oocytes, very sticky ooplasm and things like that.
But I'll tell you one thing, that success, I am practicing since many years, but what I have seen and what I have heard from my seniors also, for example, I can quote Dr. Sonia Malik ma'am, that the rates, though the labs have improved, the technologies have improved, but overall we are seeing a decline in the gamete quality. I don't know, maybe it's the food we are eating or the environment we are in or whatever it is, but there is a overall decline. Maybe the youngsters who are listening should know and try to work on improving the lifestyles and all. That is one message I would like to have to give to my
Especially donor oocyte.
yeah, especially donor.
Donor. Dr. Sujata, can you share your experience on calcium ionophore in patients where there is
The calcium ionophore is a
failure? For
very
example, are you using calcium ionophore?
it has to be used only in cases where like you have experienced low or very
Fertilization
no
failure.
fertilization. Okay. And
Yeah.
in some cases, like you could use when the sperm quality is extremely poor. Say, for example, if you're just looking at a, like cryptozoospermic sample. But otherwise, just routinely giving calcium ionophore, I have
Not
seen.
routinely. In
Yeah.
patients with fertilization failure.
Then there it
Unexpected.
actually helps.
So,
Okay, it actually helps if fertilization failure is there in the previous cycle.
yeah.
But then like these days I've noticed that, see, first cycle, though they get fertilization, they get embryos, but still, the number, if it is the number of embryos or the quality of embryos is not good, I think the next cycle they just say, okay, why don't we just do calcium ionophore? In these cases, like at least 2 or 3 of them I have noticed in the last 6 months, whatever they got in the first cycle also they have not got. Because, and then like I had asked them, like,
Yeah.
why did you use, what was the reason? Was the sperm, like globozoospermic sperm, or the previous cycle, didn't you get any fertilization? It was nothing. They just thought like it was less number of embryos, or quality of embryos not good. So this time we'll use calcium ionophore. So I don't think it works in these cases.
Yeah. And patients who have poor morphology sperm, so you will prefer peak C or sperm sorter with microfluids. So what is your choice in these two, if you have?
See, a sperm sorter with microfluidics is sperm separation, and PIXI is sperm selection. So both actually are totally different mechanisms. And in extremely poor morphology, I would use microfluidics because, if at all they can separate some good sperms, that would be helpful, because sperm selection at that level would be very difficult, because PIXI basically, the sperm has to bind on the hyaluronan droplet. If it doesn't,
Yeah.
sometimes what happens, none of it would bind. And then the embryologist is waiting for that to happen, eventually, spending a lot of time exposing both the gametes. Or sometimes what happen, all of them will bind immediately, and then you won't be able to choose because of the morphological issue. So PIXI, in my opinion, actually needs a lot of expertise. And, like I had the privilege to talk to somebody in the US who had done lakhs and lakhs of PIXI. What they say is, see, we do PIXI only in cases where previously we would have done a hyaluronan binding assay, the one on the slide, and then we know that what percentage of sperm binds to the hyaluronan, and then we actually suggest based on the percentage of binding, like this patient should have PIXI or not. But then unfortunately, we do not do that. We do not actually do a diagnostic procedure of hyaluronan binding. We straight away offer it as a, like an add-on in ICSI. So in my opinion, I feel that, like, from whatever I have observed with all these embryologists working on PIXI, many a times it does more harm than benefit.
Yeah, and you should have a good sperm count also for them. No?
Yes.
It should be at least 10 million.
Yes. See, the other day I saw 99% head defect sperm, being subjected to PIXI.
Yeah.
It doesn't make any sense at all, because, like it is, I would say that you take more time in looking at the sperm morphology and selecting it rather than spending it on a PIXI dish.
I think the crux of the discussion is that case selection is the most important thing. You have to carefully choose what is needed in that particular case. Everything doesn't apply to all.
Yes.
Thank you, Dr. Sujata. That was wonderful. And as usual, Dr. Rajapriya is like, whenever she arranges a talk or something, it is always full of knowledge, full of messages, and full of, new things. So thank you so much.
Energy
Yes.
always.
Thank you so
Thank
much.
you, Dr. Nisha. Now, if I may ask one question, Dr. Sushmita, as a young
Yes,
budding fellow, what do you think, like after reading this paper and presenting to us, and after listening to Dr. Sujata and the other seniors, do you think you would incorporate IVF once you start your own practice?
And I went through, I think, 4 different journals, And why I chose this topic is because 4 different papers have been published in all quartile 1 journals in this alone year. And the latest one is in Lancet. And all of them has told that IVF should be preferred for most of the cases, and ICSI should be the method of last resort only in cases of severe male factor infertility. One more thing that they have commented on is that fertilization rate that we are counting in ICSI and IVF are different, because the denominator in IVF is all the number of oocytes that we are retrieving, while the denominator in ICSI is only the M2 oocytes. Therefore, it has led to the false belief that ICSI gives us a better fertilization rate, whereas it is not so. And they have proved that fertilization rate as well as clinical pregnancy rate is much higher in IVF compared to ICSI cycles. So I would like to incorporate IVF.
Okay, that's nice to know. So probably we have to go back to the traditional methods and do less meddling. That I think is the message of the day, right, Dr. Sujata?
Yes.
Not run after AI and technology and allow nature to operate.
See, AI still, see, the thing is, it's an effort actually. Right now, there is no result, but it's an effort to improve accuracy, and it is non-invasive. But ICSI is an invasive procedure, and then I don't know if Dr. Priya is here. When we started, we had actually spent long time in andrology. There was no andrology technician or anybody. We do the analysis. We will only do the sperm preparation. I have stopped writing in my logbook after 5,000 analysis. Okay, I thought there is no point noting it down. Otherwise, I was diligently writing in my logbook also. So that is the kind of exposure we got in looking at sperm, every single sperm under the microscope. But then, these days, when students, they finish their clinical embryology and come, even if you put them for 1 month posting in andrology, they don't like, because they always want somebody else to do the sperm preparation and the sperm analysis. So that actually makes you less, equipped to identify the right sperm. Okay.
Yeah.
And then, you're also working against time. It's not that like you can sit on the microscope, admire a sperm, take enough time to choose. No, you have to do all these things within few seconds. So I feel that, unless we kind of equip ourselves with andrology, sometimes I feel that we are doing more harm.
Okay. So thanks for all those wise words. Thank you, Dr. Neeru Thakral, for giving me this opportunity, and Dr. Nisha Bhatnagar to handle today's Young Turks session. It was such a pleasure. And I think there is no end to knowledge seeking. So probably male infertility. I think we should start refreshing our memory on IVF. So thanks, Dr. Sushmita. We enjoyed
Thank
your
you, ma'am.
presentation.
Thank you
Thank
for
you.
providing me
Thank
this
you.
opportunity.
Thank you. It was excellent. Thank you so
Yeah,
much.
thank you,
all
Raja
for giving me the
Dr.
opportunity
Sujata
also.
and
Thank
Dr.
you so much.
Sushmita.
Thank
And
you.
lastly, I invite all the young Turk for the Fertivision 6th, 7th, 8th. Come and enjoy the Fertivision National Conference at Gujarat.
Breathe in a bit of Gujarat. And thanks to Shivam for handling the whole show on the quiz and the journal club. I think we're not able to hear Dr. Neeru.
Yeah, my internet is fluctuating. Anyhow.
So thanks to everyone and have a great weekend.
Thank you so much. Bye.
Bye. Bye.